All right, I think we're live. We're live at Chelsea. Thanks to Chelsea for hosting us today. Really appreciate you guys. We're at the community center. We're out here from 9 to 11. We got Dr. Stuart and Dr. Kirby doing lectures for us today. We're going to talk stroke and then some respiratory emergencies. We'll have lunch, and then we're going to do some skill labs with the fire college. We have advanced airway. We got our vomit head mannequin, and we'll do some cardiac arrest. So we're in Troy. 2 weeks from now, and don't forget the state EMS conference is coming up the 10th through the 15th in Orange Beach. But we'll be streaming live EMS challenge from there. But some good things, a couple things I want to mention there. There's a pre-conference event, which is the new dispatch protocols are coming out that the state's putting out. Important stuff. If you can make that, that'll be fantastic. There's also a medical director training session for docs that want to know how to be involved with an EMS agency. They're doing that on Tuesday morning, I believe. And then Tuesday afternoon the conference, there's a forum roundtable of medical directors as well. So for the docs online, for the hospital staff online, if you have a physician that wants to be involved, this is a great way for those guys to kind of get introduced to everybody. And then for those of y'all in the BRIMS region physicians, if you're interested in participating in EMS Challenge by lecturing or doing skills, reach out to me. We'd love to have more docs. EMS Challenge, we started this about 10 or 11 years ago to bring more physician involvement to the region. And UAB's been great to us. So we have our ER residents that work with us, and we have fellows, which are ER trained docs. We got docs now that we've trained here in Birmingham area. They're up in Huntsville working. They're down south, Alabama working. We got folks in Lexington and in Virginia now, all trained here in the Birmingham area. So thanks, guys, for working with those folks. So I will quit rambling. And we'll get started with Dr. Kirby then. Oh, great. Welcome to the front. Yeah. Front row guys get challenge coins. I like it. Very good. All right. Everybody else gets work, right?
Last time I started. What's up, guys? I'm Paul. I'm Ferg's bodyguard for the year, along with Dr. Sullivan. Just not here today. Dr. Sullivan's actually at Callahan working a shift. But today I'm going to be talking a little bit about stroke. We'll just get right into it. No financial disclosures. I don't get paid for doing this. These are all the mandatory slides we have to put in. So our objectives for today, we're going to go through a couple things. We're going to define stroke. We're going to do an anatomy review, talk about your field assessment, how we decide where these patients go, how you can give an effective pre-notification to whatever center you're calling to, and medical optimization going in, and then as well as why this is so important and why we need to hurry and have a quick timeline on things. Then we'll run through some cases at the end. So stroke is defined as an acute neurologic deficit from focal CNS injury due to a vascular cause. This could be either ischemic or hemorrhagic. Now, caveat there, the hemorrhagic is spontaneous bleed not associated with trauma. But for your ischemic strokes, this is an infarct to either the brain, the spinal cord, or the retina, with symptoms lasting greater than 24 hours or until death. You can have what's called transient ischemic attacks, which are kind of like small strokes that come and go, but these symptoms are going to be just transient, not lasting greater than 24 hours. And you might ask, why does this matter? Well, I started looking into it when I was doing this PowerPoint. So stroke is the second leading cause of death worldwide, and it's the third leading cause of death and disability worldwide. There are about 12 million strokes each year, and there's about 94 million people living with stroke or disability secondary to stroke at any given time. There's about 7 million deaths each year. We spend across the world $890 billion on strokes, and it's estimated to go up to 1.6 trillion by 2050. So for each dollar invested into, treating strokes or preventing strokes, you have a return of investment of $10. So 1 in 4 people will have a stroke in their timeline. About 53% of the strokes occur in people under 70, which is a pretty big amount. And then 89% of your strokes are going to be in areas of low income. So if you look at the modifiable risk factors, it's things we know about. It's high blood pressure, it's smoking, it's air pollution, it's household pollution, it's cholesterol, kidney dysfunction, glucose, all the things that we can treat. So that's why it matters. All right, so if we start looking at anatomy, okay, so we've got a picture of a brain here. Real quick, just a review of areas of the brain. You have your frontal cortex up front, and this is your executive planning, attention, and planning. It's kind of your personality, what makes you who you are. In the frontal lobe, too, on the left side, there's also Broca's area. You see in the red down here. That's going to be your speech production, so it allows you to speak. Back behind the frontal lobe is going to be your parietal lobe, and this is going to be your somatosensory integration, so your touch, vibration, proprioception, and your awareness in space. You go to your temporal lobes, which sit a little lower. This is going to be all your hearing. And then you have Wernicke's area, which is going to be like speech comprehension. You go to occipital lobe in the back, that's going to be your vision, and then your cerebellum is going to be your balance, coordination. The big part in strokes, and part of the reason I wanted to do this review first, is that you have your pre-sensory cortex and your premotor cortex, and then your presensory cortex. So your motor cortex is sitting right there in the front, and that's going to do all of your motor function, and then your sensory is going to be in the back. This is important because our stroke patients will declare themselves on where their stroke is happening according to what symptoms they're having. So I don't know if any of y'all seen something like this, but this is called like the homunculus. It's essentially little man, and they've described it as, I didn't put in the creepy picture of the little man with big nose, big hands, big genitalia and everything. But essentially most of our sensation is done in a defined pattern. So in the middle of the brain, kind of up through the middle, it's going to be your feet, and then it kind of goes all the way up the body, and to the side and outside of the brain is going to be your head, face, hands, okay? So this is important, again, because our blood flow to the brain is going to come from the internal carotid arteries up, and is going to become your MCA, your middle cerebral artery, or your anterior cerebral artery, okay? So your middle cerebral artery is going to do the outside, and your anterior cerebral artery is going to be the inside. And the blood flow to the brain, there's areas to where it can't quite reach all the way around. And so these are called watershed areas. And so patients that suddenly have a quick drop in their blood pressure, these are the areas that'll have ischemic changes, but wouldn't quite be the same as necessarily like a stroke as far as a large vessel occlusion in the MCA or the ACA. So this is kind of a picture just helping define that. So again, this is a cut straight down the middle of the brain, and your anterior cerebral arteries are going to be perfusing all of that. So if you have an insult to your anterior cerebral artery, it's mainly going to affect your legs more than your arms, okay? If you have a infarct to your middle cerebral artery, it's going to affect your hands, your speech more so than your legs. Does that make sense? So according to, you come up on a patient, you start doing a physical exam, you can kind of help determine where their lesion is. And then your posterior cerebral artery is getting most of the things in the back, and so that's when we start worrying about things like posterior stroke, dizziness, cerebellum stuff. All right, so assessment. So you get dispatched on a patient, and again, the differential for stroke is so broad, right? Like you can get called on a patient for altered mental status, you can get called on a patient for dizziness, you can get called on a patient for can't see out of my right eye, happened abruptly at this time. Stroke is pretty much always in the differential. So when you show up to these patients, you got to do the basics first. You got to check their glucose, right? Because hypoglycemia can cause stroke-like illness. Hyperglycemia and HHS can cause stroke-like illness. You want their vital signs. You want to look for any evidence of trauma, because again, I just told you that intracranial hemorrhage can be a stroke. However, if there's external trauma, your guidelines completely change. And it's really important to know last well known, again, because we'll get into it, but the timeline of things, we have to know when they were last well. And then get a history on these patients. Do they have a history of diabetes, hypertension, heart disease, smoking, any previous stroke? If you're unable to get any of that right there, the two most important things is going to be last well known and are they on any blood thinners? So that's the two most important things. As far as your assessment goes, We used to do the be fast thing, look at their balance, check their eyes, face, arm, speech, time. And now for you guys, we kind of got away from that and we've started doing the IMSA score. And so I know you are very familiar with the IMSA score, but just wanted to cover it real quick. So first for the eye movement, you're testing for horizontal gaze. And essentially, to me, this is kind of like neglect. So if they're staring off in one direction and you try to call for their name over here and they're unable to turn their head and look at you, that would be abnormal, okay? And I think it even says if they're unable to speak, if they're aphasic, then you can kind of like pinch them or do a painful stimulus just to see if you can kind of force them to look that way, okay? So if they're able to look side to side, follow commands, follow you with their eyes, then that's normal. If they're not, then that's abnormal. They get a point. For facial weakness, you can ask them to smile. Is there any drooping on one side or the other? Again, cause pain. I don't know if the pain thing would work, because I feel like if I had someone like, I don't know, Stoner rub me, I might wince in a way that one side of my face goes higher than the other, so I might get a point there at baseline. And then arm weakness, you can have them hold their arms up, palms up high, count to 10. If one starts falling or they start rotating, that's some drift, so they'd get a point for that. And then for leg weakness, have them raise their legs up if they're supine or even if on a chair. Just any way you can test for weakness there. And then naming or repetition. Do y'all ask them to do this? Do y'all actually do this in the field? I don't think I've ever done this in the emergency department. Sometimes we say it's a sunny day in Birmingham, they repeat it. Usually by then I've made the decision to call the stroke and just do all the things. But yeah, you ask them to name, is this a pen? Is this a watch? Can they do that? Great. Can they not? Negative. Or you ask them to repeat a phrase. IMSA score greater than 4 or greater than or equal than 4 is a high probability of a large vessel occlusion. Okay, and we'll kind of get into what all that means going forward. So destination decisions. I actually went back and spent probably too much time looking at the paper when this was implemented in the state of Alabama. So they wanted to make a system similar to the trauma system. And so they did and I'm sure Wes can probably help and Fer can help me out with this, but they wanted the TCC SBST, which was the severity-based stroke triage, I believe. And this was back in 2021. So this map was from 2021, and sure it's changed. But they wanted a system in where you could call in and you could talk with someone who would dispatch you to the correct hospital, whether you need to go to a thrombectomy capable center or just a primary stroke center. And it would look at their capacity of these hospitals and get you in the right direction. So it looks like, based on the map in 2021, there was only 3 thrombectomy capable centers in Birmingham. Do y'all know if that's changed? There's only 2 in Birmingham now. Is that Brookwood? Is that Brookwood and UAB? Yeah, that's okay. Yeah. Yeah. So just two. So and again, it's important that you get a good IMSA score, you get a good history, because you're going to be calling in to the TCC to try to get dispatched or try to be sent to the correct hospital. And so in order to have an effective pre-notification and discussion with these teams, you want to know last well known, your IMSA score, glucose, vitals, medical history, anticoagulation. Because in this pre-notification, you're going to use multiple times. So you're not only going to give this to the TCC, you're going to give this to me when you show up to the hospital. Give me 2 seconds and just tell me last well known, their deficits, their glucose, vitals, and then are they anticoagulated? Because at that time, I'm taking care over everything. I'm going to do my quick assessment, and then I'm going to either activate the stroke or say, no, this isn't a stroke. All right, so medical optimization. So you have decided that this person has an IMSA score greater than 4, and the question is, how do we optimize them going in? We're big in pre-oxygenation here, so we like putting people on nasal cannula and then non-rebreather. The stroke patients we kind of want to be careful with, so we don't want to hyperoxygenate them. All right, so we want to keep their oxygen greater than 94. Now, I say that if this patient is very altered or they're gagging and you're concerned about their vomiting, I'm okay with you putting a nasal cannula on them and hyperoxygenating them because you're anticipating having to take their airway. And so you want them to have a little bit of reserve. Okay. If the patient's talking to you or they're just slurring their words and they have deficits on one side, otherwise they're stable, maybe that's not the patient to put oxygen on and get them up to 100. Keep them at 95, 96. Does that make sense? As far as circulation goes, you want to avoid hypotension, but you don't want to lower them from high blood pressure, at least until you figure out what's going on. Because we have a thing called a permissive hypertensive in people with strokes. And if you lower them, if they're having a stroke and they're too high and you lower them too quick, you're just going to infect those watershed areas and cause the stroke to be worse. You want to treat their glucose if it's less than 60. And then as far as positioning, again, you kind of want them supine, and you can elevate the head of the bed if they start gagging and you start worrying about airway compromise. All right, so why such a rush? So this kind of gets into the big thing, why it's important. Again, second leading cause of death, third leading cause of death and disability worldwide. So this was a paper I found, Time is Brain. For the stroke, per second, you are losing 32,000 neurons, 230 million synapses, and you are aging by 8.7 hours per second you are having a stroke. Or per hour after the stroke, it's 3.6 years. So this kind of gets into the whole idea that these are preventable. And when you have a stroke, it's not just one and done. You are disabled. You're no longer your same self for an extended period of time. So we need to act as quickly as possible on these patients. And again, in strokes, you can have your hemorrhagic or you could have your ischemic strokes. Most of the strokes we're going to see, about 80% probably, is going to be ischemic, but you will have some hemorrhagic. So I wanted to kind of focus on the ischemic strokes, okay? And these could be either caused by embolic events, so you could have a blood clot thrown from the heart up to the brain. You could have a DVT, you could have a hole in your heart, and that breaks off, goes to your brain, or it could be thrombotic. So they have severe atherosclerosis, they're a smoker, they have high blood pressure, high cholesterol, and just over time, those vessels just become stenotic and clamp off, maybe breaks off from your carotid up to your head as well. All right, so this is a normal CT scan. So say, why such a rush? You come into UAB, we go to the launch pad. I don't know if any of y'all seen it. It's just a random stretcher in a hallway. But we do our assessment and we make the decision to call the stroke. Immediately, the patient's going to go to the CT scanner, and the first CT scan we get is a non-con CT scan. The reason being is because we need to see, is this a hemorrhagic or ischemic stroke? Okay, so we get a CT scan and it's normal. And so I don't see any blood in the CT scan. So I'm automatically thinking, according to the patient's deficits, that this is an ischemic stroke. If you transfer patients to like other hospitals, I do a little bit of work down at Chilton, they just get the non-con CT scan, go back to the room, and then they have a teleneurologist discuss the case with us in order to provide lytics there. Okay, so we don't even get the angios, which is what we would get next. So we got the non-con CT scan, no blood. So now the decision is, do we need to give lytics or not? So y'all won't be able to see this, but this is our NIH stroke score. Okay, so we use the NIH stroke score in the hospital along with neurology to determine which patients would benefit from lytics, so TNK or alteplase. 0 score would be no stroke, 1 to 4 would be moderate stroke, 5 to 15 moderate, 15 to 20 would be moderate to severe, and 21, you get it. The higher you get, the more likely you are to have a stroke, okay? And so the higher score, if they have a higher score, I got a non-con CT scan with no blood, I'm probably gonna give them lytics. And again, the reason this is such a rush is because there's been multiple studies on this looking at time, door to needle times. Okay, so the quicker we give them lytics, the better off they do. The quicker we give them lytics and transfer them to a thrombectomy capable center and they get a thrombectomy, the better they do. Time is brain. And which lytic we give them, specifically if I'm at like a hospital that's not a thrombectomy capable center, is either tenecteplase versus alteplase. UAB just switched to TNK a couple years ago. And I found a study kind of looking at why they switched. And so tenecteplase is a little easier to give. And so the time to giving it is less than the alteplase. And that not only helps you meet that time window of 4.5 hours of when we have to meet this criteria to give the thrombolytic, but it also enhances the time when you're going to transfer the patient out. So you're going to give the medicine quicker. You're going to get the patient out of the hospital to where they need to go. And it also showed some more favorable outcomes as far as less bleeding and less deficits when they're discharged.
Yeah, I'm going to throw one thing on that. The TNK is great for hospitals that are shipping to a stroke center or a larger facility because it's a one-time push medication versus giving the push and starting the drip. So it's easier to transport those patients without that drip and pumps and equipment like that. So TNK has really revolutionized stroke care. And same thing for STEMIs. So for years we had TPA for STEMIs where you give a push and start a drip and move them to a cath lab hospital. Now it's just give the push, move down the road. It's just a whole lot easier, man. And it's cheaper too, which is American healthcare. Yep.
13,000 versus 15,000 is what I got here. So I don't... Costco. Okay, so pretend I'm at an outside hospital, not UAB. I'm not at a thrombectomy capable center. So I saw this patient within the 4.5 hours, got a non-con CT scan, which was normal. They have a high NIH score, and I've given them TNK. Now they're going to go back to the CT scan to get an angio. And the reason they're getting an angio is because I'm looking for evidence of a large vessel occlusion, something they can go do a thrombectomy, okay? And so if you look at this CT scan here, on the left is going to be your non-con. And it looks pretty normal, but you see this dark area sitting over to the side, and that's where that tissue has started to die a little bit. Here is where you're seeing all the vessels light up with contrast, okay? So you see the vessel over here on the right, looks pretty patent running all the way through, whereas on the left, there's an abrupt stopped. So that's where you're having the stroke. You have something there blocking blood flow. And you can see it down here on the bottom. And so what they'll do is they'll actually go in with the catheter and they'll go and fish out this clot. And when they fish out the clot, what they'll do is they'll put in some dye. I don't know if any of y'all, they'll throw in some dye in there to look at the vessels. And so if you look at the first one here with the blue arrow, there's going to be the blockage. You're not going to see any blood flow going through. And then the next three are going to be as they're working. So they put the catheter up, they're pulling it out, and then they start throwing the dye back through, and all of a sudden you see beautiful blood flow all the way through. So this was a successful thrombectomy. Okay, any questions about any of that? All right, we're going to run through some cases here. First case is going to be pretty straightforward. And then the rest of the cases are going to be a little tricky just because I wanted to point out some things. All right, case one. You're dispatched on a 66-year-old female, sudden right-sided weakness and difficulty speaking at home. All right, what is the next thing you want to do? You show up. What do you want to do? What do you want to find out? Someone speak. Perfect. Last one known well. We'll pretend that this is the afternoon. Last one known was 2:22. You were called at 2:31. You arrived at 2:40. Okay. Sugar, I heard sugar is like 130. It's fine. Now what do you want to do? Blood thinner, no blood thinner. Has a history of hypertension and cholesterol. So you do your physical exam. She's awake. She's anxious though. And then you start doing your IMSA score, right? So in this case, let's see. I don't think I see the next one. Vitals are fine. You start doing your IMSA score right. You ask her to look to the right, and she won't look to the right. Okay, so she's just looking off to the left. You're snapping your fingers. You're trying to do everything. She's like, am I going to be okay? She's crying. You ask her to smile, and she kind of smiles, and then her right side of her face droops down compared to her left. You ask her to raise her arms, and she can't really raise her right arm. And you ask her to raise her legs, and her right leg isn't going, right? So she's hitting all of these points. So her IMSA scores 5, 6. So what does that mean for you guys? It's probably a large vessel occlusion, right? So You're going to call it TCC. They're going to probably send you to the thrombectomy capable center. All right. So as far as actions that you need to do, O2 only if your O2 is dropping less than 94. Make sure you get an IV cardiac monitor. Again, we're greater than or equal to, that's supposed to say 4. So we're probably just going to go to a thrombectomy capable center. And then for your pre-notification, say I have a stroke alert, 66-year-old female, last well known 1422, right face, arm, weakness, aphasia, IMSA score of 5, glucose normal, no anticoagulation. I'll be there in 12 minutes. Okay, got it. And then you'll say the exact same thing to me when I'm at the launch pad and we call it and we get all the things. Any questions about the first case? Going a little quick. All right, so your dispatch, 72-year-old male, sudden painless vision loss in the left eye while reading. What does this make y'all think of? Do y'all know? Any ideas? It's a stroke lecture, so it has to be a stroke, right? So anytime someone has painless vision loss in an eye, okay, we have to consider things like stroke. So they can have a clot go up to the eye, the central retinal artery. So you can have a CRAO with a central retinal artery occlusion, and it'll be painless vision loss in one eye. You could also have central retinal venous occlusion, so CRVO. You can have retinal detachment, so your retina in the back can become detached and it'll be painless vision loss. And then you can have TIAs, which is, I always butcher this word, it's like amaurosis fugax or something. But essentially their vision will go away and then it'll come back. So it's like the TIAs where they're having stroke-like symptoms, but they resolve on its own. So they can clear those little clots that they're throwing. So this patient is concerning for a stroke. All right, so these are also very important to get last well known. You might not think about it because this is a vision loss, not necessarily a weakness in one eye or the other. So last well known would be 9:12. You arrive at 9:26. They're within the window. Past medical history of hypertension, hyperlipidemia, and then this patient's going to have AFib and hasn't been anticoagulated for a couple weeks because they're supposed to have knee surgery or something. And so they've probably formed a clot in their heart, and then that clot shot up and then occluded their central retinal artery. All right. Amlodipine statin hasn't been taking their anticoagulation. Their vitals are okay, a little tachycardic, otherwise all right. So again, you ask them what happened, and they're going to say there's a curtain that came down in my left eye, but I can see out on my right eye. And you start doing your assessment. Maybe you shine a light in their eye, and there's a defect in the right pupillary reaction. Otherwise, they're intact, all right? And this one's going to be a little hard because your IMSA score doesn't really test for this, right? This is going to be up to your discretion that you think maybe this is a stroke. Now, if you come into the hospital, you didn't call anyone, you didn't do anything, but you come find the doc and be like, hey, doc, this person lost their vision, I don't know, like an hour ago, it was painless vision loss. I kind of think this might be a stroke. I'm immediately going to get up out of my chair and come see the patient, right? It's going to be hard to activate based off this. There are plenty of patients that come in with vision loss of some kind that we have to work up, and it's not always a stroke, but a lot of times it can be a stroke. So you just coming to grab me helps me be aware that I need to come see this patient. Does that make sense? So you're not necessarily going to call for this one, but you are going to come grab the doc and be like, hey, this sounds like a stroke to me. Fits. Any questions on that one? Nope. Okay.
Hey, I'll throw in something. When you talk to the docs at the hospital, I like the fact he says, go approach that physician. 99% of the docs should be approachable. Even if they're grumpy, treat them like your spouse and just smile and approach them anyway, right? Use the key phrases, make them say stroke, let them know what you're thinking. If they don't get up, not excited about it, no harm, no foul, you've done your job, you smile at them, then say, thanks, doc, what's your name? And that kind of keys us to make us think, oh, great, they're fixing to put my name on this chart about this patient they told me about. I probably ought to get up and go check them because I think they're an idiot now. You see what I'm saying? And you're not an idiot. I'm not saying that. My point to that is that gets their attention to make them move. And we've talked about this in EMS Challenge before, that you want to use some of these catchphrases to make some of us move a little faster. If you had a young female with abdominal pain that was hypotensive, I would say she's got an ectopic. Now, I can't diagnose that without labs and things, just like you can't. That makes that doc get up and move to that patient. So same thing, if you have a time-sensitive event going on that you think is a stroke, tell that doc. Try to motivate them. If you can't motivate them, you've done your job. But then ask for their name. That makes them uncomfortable, and then they actually get up and go see that patient.
Yeah, yeah. I'll jump up. Someone was telling me a story the other day that they had pre-hospital called a stroke, and that they went to the hospital, and then the physician was like, "It's not a stroke," and they were feeling bad about it. And I was like, "Hey, look, like according to what you told me, that sounded like a stroke." And I would take on a lot of liability as the doctor if you activated a stroke in the field and they were within the window, they had symptoms, and then I would say no. And so I told them, like, if you came into me with someone like this and you activated stroke, I'm just going to keep the ball rolling, and then we'll prove it's not a stroke, and then we'll go from there. But I wouldn't let something like that make you hesitant to do the things. Because we make mistakes as well. I didn't necessarily agree with that one from the hospital emergency medicine doctor standpoint, but you got something to add to that or no? Yeah. Yeah, do the things, don't get discouraged. All right, case 3. So dispatch, 64-year-old sudden right-handed clumsiness and slurred speech at lunch. All right, what do you want to know? Last well known, 12:18, you arrive at 12:34. Now what? Same things. Yeah, blood sugar, vitals, everything's stable. Okay. But now you start to assess the patient, right? And everything's normal, right? So you ask them to look left, right, it's all normal. You ask them to raise their hands, normal, feet, normal. You ask them, is this a watch? Is this a pen? Can you repeat this? Everything's normal. Glucose is normal. Everything's normal. And again, you arrived within an hour after they had weakness in the right leg, right arm, difficulty speaking, whatever. So her IMSA score was a 3, but now it's a 0. So what do? You treat this like a stroke alert despite all the resolutions, okay? So this is a TIA. This patient has concerning signs for a transient ischemic attack. So they had a small stroke, and then they were able to clear it, and their brain got enough blood flow. This isn't something that you're going to call in and activate, but it's something you need to make the docs aware of when you get there, okay? So possible TIA, 64-year-old female, last well known, 12:18, right hand, clumsiness, slurred speech, since resolved, glucose normal, vital stable, be there in 10 minutes. Now, the next question is, what happens when you're 10 minutes down the road and she starts developing the symptoms again? Anyone have a guess? Activate it. Yep. You call back and say, never mind, her symptoms are back. We need to activate this. Because when you're having a TIA, your risk of a stroke within the next 24 to 48 hours is astronomical. So they need to go to a center. They need to get the CT scans. They need to be medically optimized at a minimum. So they'll get the CT scans, they'll get the MRI, they'll be placed on aspirin, Plavix, or torvastatin, and then hopefully discharged at a pretty quick time period. But if they start having more stroke symptoms, and I've had multiple patients in the emergency department like this, where they come in and they have some symptoms before they got there, they resolved. And then all of a sudden, a nurse comes to get me and goes, hey, she's not looking to the left right now. And in my head, I'm like, oh, shit. Because you think you missed it, but the thing is that they didn't have a stroke. They had cleared a TIA, and now they're having a stroke. So then you activate everything all over again. Any questions about TIAs? So again, not necessarily calling to activate if the symptoms have resolved. It's something you're grabbing the doctor for, making them aware. And if their symptoms pick up when you're on the way in, then you are going to call and activate. Cool. I think I got 2 more cases. The last one's kind of fun, interesting. All right. 58-year-old male witnessed convulsive episode at work, now has left arm weakness. So his head and eye is, he had like a seizure, right? So he was shaking. It was mainly on the right side, tonic-clonic, 90 seconds. Now he's awake, but he's weak on the left. He has a history of seizures, but he's been off his Keppra. His vital signs are normal. What does that make y'all think of? Anyone know? Called Todd's paralysis. So you can get something called Todd's paralysis after a seizure. Essentially, your brain didn't get enough oxygen during the seizing, and now there's some transient weakness, right? So you're going to get an IMSA score in this patient, and maybe they're able to look left, right, but they're weaker on the left side, I believe. So they're weak on the left upper, left lower. They're able to repeat things, or maybe they're not. Maybe they're postictal a little bit. So your IMSA score is going to be a 3, maybe a 2. So it's not necessarily greater than a 4, so you don't think large vessel occlusion, but it might be worth calling in to talking to someone or letting someone know you're coming in. I wouldn't necessarily activate it with a story like this. The problem is there will be times when you're dispatched on people like this and you won't get this history, right? Like a family member would be like, I don't know what happened. I went to the store and I came back. All of a sudden, he can't move his left upper and lower extremity. It's a little different, right? So you're going to get your IMSA score, your glucose, all the things. You're going to call it in, you're going to take it, and you're going to get the CT scans. What really helps us in the emergency department is the fact that I can see medical history. I can see all the charts. Y'all can't. So a patient like this comes in, maybe I do the stroke stuff and I pull up the chart and he has a history of seizures, non-compliant with medications, or he does other drugs, and then he has documented history of Todd's paralysis. I'm still probably doing the CT scan and everything just because, again, time is brain, but it's probably a Todd's paralysis. All right. And these get better pretty quickly. So their weakness will get better as you're going in. They usually don't last too long. And again, if it's a high IMSA score when you first get there, just go ahead and call it in. Any questions on that one? All right, last one. This is a true case that scarred me for life. All right, so 59-year-old male came in with left arm weakness, word finding difficulty. Last known well was at 10:06. Okay, so they come in, has a history of hypertension, smoking. He did have some upper back pain last night that has since resolved, but woke up with all this weakness, not on anticoagulants. And his vital signs, his blood pressure was 188/92, heart rate 88, otherwise stable. Okay. So this is a patient that came to me in the emergency department concerning for a stroke. Sounds like he's having a stroke, right? So we do the things, right? I get a CT scan of the head. This was not me, but this was a case that I took over. CT scan of the head, normal CT scan of the head. Okay. We do the NIH scores. NIH scores, I don't know, 15. Right, so we made the decision, it was within the window, that we were going to lyse this patient. I keep saying we, and I don't need to say we. Whoever was taking care of the patient made the decision to lyse the patient. All right, so there's no hemorrhage. You didn't get the CT's head and neck just because there's a Q. Glucose is fine, blood pressure is fine. You give the T and K. Shortly after, things start to change. Right? So this patient starts getting better, but then all of a sudden gets worse. Did anyone catch something in the history that should have raised a red flag? Keep talking about it. All right, so after you give the T and K, about 30 minutes, the patient develops sudden chest discomfort, diaphoresis, agitation, then becomes hypotensive and tachycardic. Ringing any bells yet? On exam, you have some JVD, you have muffled heart sounds, and you have cool extremities. And then you get a quick x-ray and you have widening of the mediastinum. An aneurysm, right? You do a point of care ultrasound, you look at the heart. He has a large pericardial effusion with RA and RV diastolic collapse. He's in tamponade. And all of a sudden, the rhythm goes from sinus tach to PEA arrest, and then you get ROSC after you do a pericardial stentesis. You put a needle into the heart sac, drain some blood, you get ROSC back. So what happened in this case, and I've seen it twice, mainly from transfers to where they do this exact thing. So someone comes in with a weakness, they get a CT scan of the head, non-con, there's nothing there. They have a high NIH score, so they give them lytics. when you have a type A dissection, you can have dissection up into the carotid arteries and can cause stroke symptoms. So anytime a patient like this says that he was complaining of back pain last night, or they're complaining of chest pain, I get CT scans all the way up just because I don't want to miss this. Okay, it's a different algorithm. You don't want to give them the lytics. So the patient I saw was seen at outside hospital, given lytics. Then they went back at the CT scan. They showed that he has a dissection here in his aorta, and it's going up the bilateral carotids, causing his symptoms. Okay, so you had just thinned the blood in an area where the blood does not need to be thinned. He developed a pericardial effusion, and we had to do a pericardiocentesis. The problem when this happens is that there's not too many vascular teams that are going to touch the patient after you just lyse them. So I just thought that was an interesting case. So if you ever have a patient with a deficit that's or back pain, make sure that the doc's aware of that. Okay. All right. That's it. That's all I got. And
Yeah, that's a scary case there. So, we've talked in the past about if you have a patient that you're doing a 12 lead on, they have a big STEMI and they're having chest pain, but yet they have neurological deficits. You got two things going on. I've been asked, do you put them in the stroke or the STEMI system? And I say, well, actually, they're probably having a dissection. So sometimes that's an easy diagnosis, right? Guys sweaty, hypertensive, EKG is all jacked up, showing a STEMI, but yet they're having a large stroke. That's a dissection until proven otherwise. And like you said, once you give somebody TPA or TNK, there's not much intervention you can do. I've seen strokes get TNK, they don't get better, they're altered, they end up getting intubated, which is a fairly benign-ish procedure, right, to cause bleeding. But that tube is placed too deep, is right main stem. Now they have a small pneumothorax, they need a chest tube, but you just gave them TNK, so now they're going to bleed where you put a chest tube. So there's a risk and a benefit to everything. But yeah, those are scary. I'm like you. I always get a 12 lead on all my strokes. Now I'm not going to stop the CT scanner for the 12 lead, right? But a 12 lead to look for ischemia, because if you got that dissection that goes back to the aortic cusp, you'll see a STEMI. And I get a chest X-ray as well, just to make sure I don't see anything weird. Same thing that I do for my STEMIs. If I've got a STEMI that I'm going to lyse at a small community place before I ship to a cath lab, I'm getting a chest X-ray. And I know, these residents here are probably getting ultrasounds on them, but I like the chest X-ray. I can read that better. So.
So we had one question about apparently this person had a case where a patient had some pretty profound stroke symptoms, received the lytic, they seemed to resolve, and then some hours later the stroke symptoms returned. So is that something that y'all have seen before? Or
oh yeah,
what's the cause of that?
Oh yeah. If something like that happened, so I had a patient with stroke symptoms, came in, we gave them lytics, they improved, and then all of a sudden they're developing these symptoms again. I'm doing all the things over again. So I'm specifically getting a knock on the head because I'm worried that they had a stroke and I gave them lytics, I thinned their blood, and all that tissue that was originally poorly perfused had started to die, and I've thinned the blood, and now they have a bleed in their head. So I'm concerned that they've converted essentially from ischemic to hemorrhagic.
Yeah, the other thing is sometimes you have these clots that are really big and you can get enough perfusion to make them feel better, then it kind of reclots again for whatever's causing that process. But the biggest risk is change from a ischemic to a hemorrhagic stroke on these folks. Yeah, which is pretty scary, because what do you do then? If you give them medicine to reverse that blood thinner, that stroke's going to get worse. So it's challenging. It's worst case scenario, right?
And I didn't put it in my note, but you can get something called recrudescence. So on all your patients that have had prior strokes, you'll be called out because they're having left-sided weakness or something, and you'll start talking to them. All of a sudden, you find out that they have a temperature, they've had some cough, they're septic appearing, and then, oh yeah, I had a stroke years ago with left-sided deficits. And essentially all that is that their bodies, their demand has gone up from an infection or something else, and they're not perfusing that area of the brain as fully as they originally were. Does that make sense? So they're going to mimic their old stroke. I say all that because even if you're in the field and you get an IMSA score greater than 4 because of their deficits and you think it's not a stroke, it's sepsis, I would still do the stroke things because we're going to have to do all the stroke things and then we can treat the sepsis, or we can do it at the same time. But
Yeah, about a third of the patients put in the stroke system actually have a stroke.
Yeah.
About 2/3 to more are admitted for some kind of significant neurological insult. The point of that being, strokes are hard to diagnose sometimes. You can do it with imaging, which you guys can't get, and sometimes it takes us a while to get. So if you're concerned about a stroke, start the process, because if it is, we have ways to fix it if it's ischemic or make it better. But you will miss several of these, and that's okay to overcall. Better to overcall than undercall.
So, hey, Dr. Ferguson, we also have a comment about the stroke system referring patients to rural level 3 centers who consistently refuse to accept the patients when they won't even treat walk-ins. So they'll tell us, don't bring them here. What's the
So if a hospital has designated themselves as a stroke system center, they should accept those EMS patients if they're on green. So if TCC gives you the clearance so that you can go there, you should be able to go there. If you as an EMS provider or an EMS agency are seeing a patient that gets to a stroke center and you feel does not get the stroke care they need, that needs to be sent to us at BRIM, sent to me or Mr. Minor, so we can evaluate what's going on. Stroke hospitals, they volunteer to be in the system. The state approves them. They are aware of the guidelines and the rules, just like for trauma and STEMI. So if there are issues, please reach out to us. But the reason we do this is we can't have every stroke going to one of the 2 LVOs in Birmingham, because they would be so full they can't take the ones that we find that have the large vessel occlusions. So we got to utilize the smaller places to screen out that 2/3 of patients that aren't the stroke, so that we can use the system to its fullest. Does that make sense? Yeah. It's sort of like running a tiered response, BLS and ALS, right? You can't send, your one ALS truck to every call if you got BLS trucks too. So great talk. I had a few things I was going to say. He mentioned not using oxygen on strokes if they're not hypoxic, and that is reasonable to do. American Heart recommends that, as does the neurological societies. And the reason there's free radicals and things of that nature. If you've heard me talk about it, I am very pro prevention of hypoxia. So my suggestions on that is that these guys maybe get a nasal cannula, but it's not turned on, because the risk would be that if you're in the back of the truck by yourself with that patient and now their stroke becomes worse and you need to start some O2 on them, then you're kind of fumbling around. If it's already on there, all you got to do is crank it up. 2 types of strokes, ischemic and hemorrhagic. I get a lot of questions about blood pressure control in these patients. I know that there are some medications approved for use for EMS for blood pressure control. My suggestion is you do not treat blood pressure in the field on anybody that you think is having a stroke until you get a CAT scan. Yes, I know that hemorrhagic strokes present usually with headaches, worsening neurological status. They're hypertensive. Sometimes they seize. But occasionally ischemic strokes present that way too. So my thoughts on blood pressure management: if you have a patient that is in flash pulmonary edema, they're sweaty or having a STEMI or cardiac event, and they're hypertensive, you treat them with nitro, right? If you have a patient that has an injury, complaints of pain, and is hypertensive, you treat that with pain medications. If you have someone that's having neurological symptoms and they're hypertensive, you don't treat that blood pressure until you get that scan. Now, if you're a critical care and you're taking their airway because they're obtunded, that positive pressure will lower that blood pressure a little bit for you. If you need to sedate them, that's reasonable. The blood pressure will drop with that. But my suggestion is you should not be using antihypertensive in a patient with neurological symptoms until you see that head scan. Because if it's ischemic, that elevated blood pressure is going to perfuse the part of the brain that you can salvage. If you lower that blood pressure, you just made their stroke that we can't maybe fix a lot worse. Does that make sense? So I know everybody freaks about a blood pressure. Is a doc, if you walked into the ER with me and your blood pressure was 210/110, I'm like, yeah, no harm, no foul. Do you have end organ damage? So are you having a heart attack? Are you having a stroke? Are your kidneys jacked up? We're looking for things like that. How many folks in Alabama have hypertension? What percentage of your patients do you think?
All of them.
All of them say, yeah. Well, y'all may have some healthy people out here in Chelsea, but I can tell you in the greater Birmingham area, most of us have hypertension and diabetes and or worse, right? When you're asking about your stroke checklist, last known well, super important. So if dude went to bed at midnight, normal, and woke up at 6 a.m. because he overslept and the wife was mad, and when he woke up and the wife came out of bed, he's not using his left arm, and she calls you at 7, when was his last known well? Midnight. So he is out of the window of thrombolytic therapy, but he's still in the window for an LVO, right? Cool. What questions y'all have? Great talk, sir.
Yeah, so we had one person online ask, what are the telltale signs of Bell's palsy? Or is there any special differential for stroke and Bell's?
Facial sparing, essentially. So like they're one side of the face, they won't be able to move at all. So in a stroke, they will be able to move. Am I correct on this, right? So in a stroke, they'll have like right lip drooping, but you'll ask them to raise their forehead and their eyebrow will be able to be raised. In Bell's palsy, which is most likely from a viral infection or some type of infection, their entire face is going to be drooping.
Yep. The other thing is they have no other neurological symptoms. Now, can you have somebody that has a stroke that it just affects the face? Yes, I've seen that and I've been burned. So if you have a person that's having facial weakness, I would recommend you do your assessment, you get your last known well, you get your Accu-Check, you're doing your vitals, you do your history, and then you do your exam. And when you get your IMSA, you put them in the stroke system, and we work it out at the hospital. Because I've had older people that have Bell's palsy that's just enough that makes me think, I'm not sure. I'm going to pull the trigger and move with a fastness to see if they're having a stroke or not, because sometimes you will get burned, right? Yeah. Bell's palsy is usually short-lived. Most folks get better in 7 to 10 days or maybe a little bit longer. Strokes, people don't get better, and you don't want to have that facial weakness lifelong. So.
Yeah, I'd rather apologize for calling it a stroke and then it not being a stroke than the other way around.
Yeah, I want to go home and be able to sleep at night or sleep in the day when I work at night. One of the two. Yeah.
So, Doc, thinking about transport logistics, if we take an ischemic stroke patient to a hospital that gives them TNK, and then it's determined at that hospital that it's a large vessel occlusion that needs to be transferred out for a thrombectomy, does the administration of the TNK or TPA prevent them from having that procedure done?
No, I went down a rabbit hole last night looking at the data on that. So they do like component therapy versus just thrombosis or thrombectomy. And there's really no difference. And I think it's provider dependent. So like at UAB, some of the providers will say, go ahead and give it, and then we'll take them up. And some of them say, no, hold it, and then we'll go up. So it's not going to preclude them. The biggest thing is when you're at some of these small hospitals, the TNK is the only thing we can do for those patients at that time. And again, time is brain. So the quicker we can give them something to help perfuse some of this brain, the better.
Yeah, it's sort of like STEMI care used to be, right? So you would lyse them while you wait for the cardiologist to come in. Now we have cath labs that are open more, right? So you want to try to open up that vessel as quick as you can to restore perfusion to the brain so the brain doesn't die. So there's a risk to that medication. That's why you do your checklist to say, hey, any recent surgery, any history of aneurysms, et cetera, et cetera. Are you on blood thinners? If they're on blood thinners, we don't give that thrombolytic because that makes their blood too thin. Now, that's the redneck definition, so I apologize. That's the way I talk, right? But there's a risk to that. And then we take them in and do that thrombectomy afterwards. So like Dr. Kirby said, sometimes you do it one way, sometimes you do it both. Just depends.
So I know that in some parts of the U.S. And other countries, EMS is carrying Retivase and treating patients with stroke symptoms.
Not strokes.
Is it not strokes?
No. It's STEMIs only. Yeah, you're not going to give a lytic to anybody with neurological symptoms till you see that scan, because if it's a hemorrhagic stroke and you give a thrombolytic, what did you just do to that patient? Yeah, you just made their family rich because they're going to get all your insurance, right? You just killed somebody. So no, you're not giving a thrombolytic till you see a scan. Our practice at UAB is that when that stroke patient shows up, we follow them to the CT scanner. So we as the ER doc, in addition to the stroke team, are looking at that scan to say, is there blood or not blood? Because we know that's all time sensitive. If we see blood, then we're done. There's no more time sensitive issue. We're not going to give them a thrombolytic at that point. So, bleeding in the brain is bad.
So is there any real treatment for intercerebral hemorrhage or hemorrhagic stroke?
Yeah, so it's supportive care, just like head injuries, right? So you want to prevent hypoxia. We know hypoxia is bad. You want to manage the blood pressure, and that's kind of dependent on what agency or what health system you're looking at. I think our state protocols say you want to get the blood pressure less than 160. And that just kind of depends on the neurosurgeon as well, but that's a pretty good number. Elevated blood pressures make you bleed more, but you also got to remember you have somebody that is having a hemorrhagic stroke. You still don't want to get them too hypotensive because you want to perfuse the part of the brain that's not being damaged by the bleed. So it's kind of tricky. So you want to prevent hypoxia, you want to manage the blood pressure. If you take their airway as a critical care crew, you want to make sure you're not blowing off that CO2 because that's bad as well. So you want to prevent hypercapnia. Hyper or hypo? I think I'm having a stroke. You don't want to blow off the CO2. Yeah.
You want to avoid both, to be fair. You want
Yeah.
Yeah, I would say avoid both.
Yes. Yeah, both.
Thanks, Dr. Kirby, for a great lecture. We're going to take a few minutes break, give everybody a chance to stretch your legs, and then we'll be coming back with Dr. Stuart. So please don't go anywhere. We'll be right back.
Okay. Hey, I'm Kinsley. I'm one of the second-year emergency medicine residents, and today we'll be talking about asthma and COPD. These are our disclosure slides that we have to include. All right. So objectives today, we're going to talk about the pathophysiology of asthma and COPD, as well as their distinguishing features. We're going to talk about how to recognize and assess the severity of your patient that's in respiratory distress, performing a rapid assessment and initiation of evidence-based therapies, and signs and symptoms of impending airway failure. And then we're also going to talk about special population considerations like pediatrics. So why are we talking about this? Asthma, we'll start there. In the US, it affects over 25 million people. 8.7% of adults are affected. Higher prevalence among women, non-Black, Hispanic, non-Hispanic Black individuals, and lower income and obesity. Most common chronic disease of childhood, it affects 9.5% of children. We have about 2 million ED visits a year for acute asthma exacerbations. Half of those are children, and then more than 4,000 patients with 185 being children die annually from asthma attacks in the US. COPD affects about 5% of the population. It's the third ranked cause of death in the US behind heart disease and cancer, and it's responsible for 154,500 deaths annually in the US. So it accounts for nearly 20% of our hospitalizations in age greater than 65. So lots of reasons to know about this. So first, taking a step back, I was going to talk about pulmonary diseases as a whole. So we have obstructive and restrictive. Today with asthma and COPD, we're going to be focusing on the obstructive pulmonary diseases. So this is asthma and COPD are different in many ways, but they do overlap in that the overlying physiology is similar. They're creating an obstruction in the airway that's preventing the lungs from completely emptying past that obstruction, and you can have air trapping, whereas restrictive is a little bit different, but we're not going to talk about that today. So I'm going to keep going. So talking about obstruction again, looking at the picture on the left, you can see when on this left side, the alveoli that's been blocked out, that's supposed to represent an obstruction in the airway. So if air cannot get past that obstruction, or there's very little air getting past that obstruction. Doesn't matter how much blood flow you have to that alveoli, they're not going to exchange any oxygen because there's none there, or there's very little. So what will happen is it'll shunt over to the well-ventilated alveoli, and those alveoli that are perfused will have oxygenated blood, but overall you'll have a decrease in oxygenation, forming a shunt. Now, asthma. So asthma is characterized by chronic inflammation. This is most commonly due to a genetic predisposition that causes your immune system to develop specific antibodies against different environmental allergens or different pollutants or noxious stimuli. And it has like this hyper response to whatever is aggravating your immune system. So the two kind of hallmarks are airway inflammation and bronchial hyperresponsiveness. So first, which this picture, probably not easy to see, but it's a little bit better. If you look to the left, the idea is up top, something comes in, say it's dander, it's dust mites, it's something that's going to activate your immune system. Your in asthmatics, they have this hyper response, so they'll activate all of these inflammatory cells along the pathway. B cells that'll create antibodies that'll release mast cells, and ultimately it's going to lead to increased vessel permeability, so you'll have really leaky vessels and have a lot of edema in your airway. It'll also lead to bronchoconstriction, and it can lead to just mucus production up top. So a lot of gunk and constriction of airways there. Now, they talk a lot about the vicious cycle of asthma exacerbations. So, patients can vary, but the central pathophysiology is once they start having this inflammatory response or immune response, they start to feel a little dyspneic. They'll start breathing faster. They'll get anxious. It'll lead to, as they're taking deep breaths in and getting some air past the obstruction, it's getting stuck and they can't exhale it all the way out. So it just leads to more and more air trapping. And then that worsens their dyspnea and worsens their anxiety. So it's just sort of this vicious cycle. And we're going to talk about different ways or how we're going to treat this out in the pre-hospital setting. But we have our albuterol or our beta agonist and our steroids to help open up the airways. And we can talk about some non-invasive mechanical ventilation to help push some air past that obstruction. And yeah. So COPD is a little bit different. So I think of asthma as sometimes these people have a genetic predisposition that overexcites their immune system, kind of like we talked about. COPD is more of a chronic airway inflammation, but it's from significant prolonged exposure, primarily to smoking cigarettes, or in some cases occupational if they're industrial smoke exposure. But over a long period of time, a significant constant exposure to this leads to just chronic inflammation in your cells, similar to what we talked about with asthma, but a little bit different. But ultimately will lead to tissue destruction of the tissue. So kind of the takeaway is, say for smoking cigarettes, for example, that creates a lot of inflammation in your body. Your body over time is trying to heal itself, and through that process, you'll start having some breakdown of tissue, and then it continues over time, and you just have progressive worsening of your symptoms. Whereas with asthma, it's more of these episodic events that only happen whenever you're exposed to something that may trigger you. And ideally, you know your triggers and you avoid them. So what are we going to see when we have someone in respiratory distress from asthma COPD? Hallmark symptoms, dyspnea, cough. You'll hear diffuse wheezing. They may complain of chest tightness. We talked about the key differences in asthma. These are episodic, they're reversible. There's some trigger that causes cascade of events, and hopefully as we treat and give them the medications they need, they improve and go back to sort of their baseline. COPD, on the other hand, is chronic, it's progressive. It can get transiently worse if there's some aggravating factors, but for the most part, these people have some chronic underlying symptoms. So some common triggers for asthma: environmental allergens, irritants, respiratory illness, extreme weather, really cold weather can exacerbate it. A lot of these patients will know what their triggers are. Exacerbation or any sort of heavy physical exertion can trigger asthma, and then emotional state, stress. COPD, on the other hand, 70% of COPD exacerbations are by viral or bacterial infections, and then 30% are environmental factors or unknown. Okay, so other things to consider when we have someone with respiratory distress that's coming in with cough, dyspnea, wheezing. These are things that we don't want to miss. We want to make sure that, and we'll talk about some of the questions that we can ask. We're still considering, like, are they having an anaphylactic reaction? You know, do they have a PE? Are they sick? Do they have pneumonia? Is it a little kid and they were found in the playroom and maybe they aspirated some toy? So these are sort of my top differentials when I'm thinking through. Okay, so pre-hospital assessment, you get to your patient, they look like they're in distress. Some of the things that you want to ask them, things are here, but when did the symptoms start? Do they know the trigger? Do they have a history of asthma, COPD, heart failure, past allergic reactions? Kind of gauging their severity. A good question that I ask sometimes is, have they ever required admission before, or have they ever been intubated, had an ICU stay? That can kind of give you an idea of where we're headed. And then for our COPD patients, are they on home oxygen? If they are, how much are they on? Has that increased over the past few days? And then some of these other questions, like we talked about with, do they have a fever? Do they have purulent sputum, something to make me think infectious rather than just COPD or asthma? Do they have a rash? Do they have pleuritic chest pain that would make me think that would be? Yeah, other questions like that to think about. And then physical exam, vitals, pulse ox, assess their level of consciousness. A lot of the times whenever these patients are retaining a lot of CO2 or carbon dioxide, they can get pretty somnolent. And then a lot of them will have increased work of breathing because they're having to use their accessory muscles more to push past that obstruction. So they'll tire out pretty quickly. And breath sounds. So severity, mild to moderate. These patients will typically be able to have a conversation with you, talk in phrases, talk in sentences, not really agitated, respiratory rate 16 to 30, heart rate 100 to 120. So could be a little tachypnic, could be a little tachycardic, but maintaining their sats, they're able to sit up and talk with you for the most part. When you start to worry is when these patients can only get out single words. You see them hunched forward, they're tripoding. You see that accessory muscle use, they're tiring themselves out. They seem agitated, they're sweating. At this point, they're very tachypnic, tachycardic, their sats are dropping. And then a scary finding that I hope I don't encounter, but I know I will at some point, is silent chest. So lack of wheezing. When we think of these exacerbations, the first thing you think of is wheezing when you're listening to their breath sounds, but just because no breath sounds does not mean that they have good breath sounds. It could be that the obstruction got to a point that it was so severe that they're not passing or moving any air. They're not ventilating anymore. So silent chest, very scary sign. And then impending respiratory failure, are they cyanotic? Do they look blue? Are they, like I said, worsening mental status? Are they not able to maintain their respiratory effort? They're fatiguing. All things to look out for. So talking a little bit about capnography, because that can be helpful with this. The classic appearance that you see on these for obstructive physiology is going to be a shark fin appearance. So this is from, again, the airway obstruction. So you're having delayed emptying of that alveoli, and as it's emptying, you're exhaling CO2 unevenly. So it leads to this kind of sloped appearance. So let's see. Yeah, so this can be helpful in identifying that you have an obstructive pathology and then watching their end tidal at the beginning. If it's early stages and it's pretty mild, it could be low, it could be normal if they're tachypnic, blowing off a lot of that carbon dioxide. But as it gets more severe, you can start to see a rise in the CO2, and that's telling you that you're having worsening mismatch and overall not doing well. So big takeaways: shark fin, think airway obstruction, asthma, COPD. If it starts to rise, the patient's fatiguing, start to get your stuff ready and prepare in case your medical management's not working or non-invasive. And then it's also good for if you give a treatment and you can watch, and if it looks like it's returning to normal, then you know you have a positive response. So it can be helpful. So pre-hospital, we've done our history, we're placing our pulse ox, we're getting capnography, putting them on the monitor. Supplemental oxygen, SAT goals. It's going to be different in COPD. I didn't put this on here, but goals are going to be a little bit lower than they would be for asthma exacerbation. So COPDers are going to be chronic CO2 retainers. Their body is adjusted to living at a higher CO2. We don't want to just load them with oxygen and take away their respiratory drive. So they can sit at about 88 to 92 would be goal. And then, asthma exacerbation can be a little bit higher. And then in pregnant patients specifically, you want to go for a goal of greater than 95%. Now talking about therapies. So first line therapy, when you get there, have everything hooked up, you want to give albuterol. Now you can give albuterol and ipratropium, and I would say to do that if you can. But the important thing is to get albuterol in, and we're going to talk about why. So albuterol, 5 milligrams nebulized, or you can do 2 or 4 puffs. You can read this. And then the albuterol ipratropium is 3 and 0.5 milligrams nebulized, and you can repeat. And you want to stack these treatments and just do it back to back. Get IV access and give steroids as early as you can. You can give here, I took this from the Alabama EMS protocol, but 125 methylprednisolone IVIO is what I think you'll have in your cars. But if for some reason you can't get a line, I don't know if you have oral pred. No. Okay. Well, they work the same, but we're going to give that. But yeah, give that as soon as you can. That's going to help with the inflammation, and we'll talk a little bit more about it. But it takes a little bit longer to kick in, and it can really help a lot. So you're giving them back-to-back treatments. You've given them the steroids, still not looking good. Second line therapy at this point is going to be MAG. So you're going to give 2 grams diluted over 20 minutes. This is going to be the first thing you grab for a second line treatment in adults. Epinephrine is going to be your primary second line treatment in children, and we'll talk a little bit about that. There's certain situations where you can give this in adults. It's more of we just don't have great research to back it up right now, and there are some risks with side effects in the elderly, history of heart disease, just with the alpha receptor activation that causes vasoconstriction, hypertension, just some side effects that may not outweigh the benefit of giving. And then lastly, non-invasive mechanical ventilation, so CPAP or BiPAP. Kids, same thing. I highlighted the differences. It's just going to be difference in dosing. So still going to give the albuterol or the Duaneb, the albuterol ipratropium. Still going to give steroids. The methylpred, instead of just being the 125, it's going to be 2 mg per kg for a max of 60. And then second line in kids is going to be epi, and that's the 0.01 mg per kg, or 0.3 milligrams IM. And then, okay.
Yeah, I want to throw a few things in real quick. Sorry.
Yeah.
I've had caffeine and I'm back here pinging now. Sorry about that, guys. So I think some of the big points she mentioned, I wanted to stress as well, is recognition of sick patients with asthma. Did y'all hear the questions that she asked for asthmatic patients to make you kind of think, are they sick or not sick? Did y'all pick that up? Yeah, so I would say most of them probably have accessory muscles, but kind of a history question that we like to ask is, have you ever been admitted to the hospital before for this? So you see a lot of patients with asthma, especially in the deep south in the spring when everything's in bloom, right? So there's all kind of types of asthma, but there is a real disease out there, asthma, that kills people. And I see probably 3 a year in our region from the EMS side that have bad outcomes, and it's a young person with the asthma attack. There's probably more, but I know about 3 a year, right? So it's probably more out there. So asthmatics who have the real disease are scary to manage. So question I always ask every asthmatic, you ever been admitted to the hospital before? If they say yes, that lets me know that they have underlying disease that causes significant problems. The next question I used to ask was, you ever been on the ventilator? And they all said yes. I'm like, what in the world's going on? And they meant the nebulizer, right? The puffer, not the puffer, but the machine. So I kind of changed it to, you ever been put in the intensive care? If they say yes to that, that patient makes me uncomfortable. My sphincter tone goes up pretty high because those guys can have problems that it's hard to salvage them from. So every asthma patient is going to get my assessment, my exam. I'm going to think about things to do. I'm getting the vital signs. I'm getting a stat probe. I'm going to do oxygenation. I'm going to do medications. But the ones that say yes to admissions, especially ICU admissions, those guys I'm moving with a purpose, moving a little bit faster. So I like the thought of oxygen. O2 nasal can is a great way to do it. Provides, I think, high flow even to adults. I use that first. She mentioned epi. Epi-IM in an asthma patient is a great bronchial dilator. We used to use a drug called terbutaline. I know some guys here probably did too from years ago, but Epi-IM is great. I would recommend that all medics know that dose in your brain, memorize it so you don't have to look it up. It's super easy. It's 0.3 mg IM if they're 30 kilos or bigger, and it's 0.15 IM if they're less than 30 kilograms. So if I had an asthmatic that I'm looking at that's working hard to breathe, makes me uncomfortable, and I'm the medic on scene with a couple of other partners, I'm going to have somebody throwing the O2 on where they're getting the vital signs. And as I'm doing my assessment, I'm asking this question. You ever been admitted before? They say yes. I get nervous. You ever been in the ICU before? They say yes. I'm really nervous. At that point, I'm done talking. My crew is doing the O2, doing other things. If someone's there that can set up an IV access, they're going to do that. And I'm reaching over and grabbing my Epi-IM. I'm doing my Epi-IM. I'm doing my neb treatments. What steroid do y'all carry in Chelsea? Y'all carrying steroids? Solumedrol? Yeah, so solumedrol is a great drug. Early, the better. It takes a while for it to work, so methylprednisone is great. There are some other drugs, steroids you can carry, the state says as well. So anybody carrying Decadron or hydrocortisone. So those, if you don't have solumedrol, you have other steroids. Know your dose, talk to your med control, your offline med doc, and get those down. I'll be using those early on. Decadron, injectable, you can actually squirt that in the mouth hole and give that orally. So if you didn't have IV access, you could do Decadron that way. But it's oxygen, epi, albuterol. We're talking about the solumedrol. And then in the folks that have that significant history, I'm either thinking even some magnesium or some CPAP. For critical care guys, it's BiPAP. And for critical care guys, I would not be intubating these people unless they stop breathing, because once you get them intubated, it's tough to manage them on the ventilator. But I'm talking way too much now. I'm getting that eye contact from Dr. Stuart, so I'll be quiet.
No, that's good stuff.
Sorry.
That's good stuff. Okay, so talking a little bit about the drugs that we're using and why. So albuterol is our inhaled short-acting beta agonist that we give. It is going to relax our smooth muscle around the small airways that are constricted during these asthma exacerbations, COPD exacerbations. Takes about a little less than 5 minutes to kick in. Some side effects just to be aware of. You can have some tachycardia. Technically, you can have transient shift in potassium, so some hypokalemia, but I feel like the big one would just be tachycardia. Some things I found in articles that I thought were interesting, and maybe Dr. Ferguson can comment on this. So one of the things that they mentioned when I was looking up or researching this, continuous therapy could lead to improved outcomes, decreased rate of hospitalization compared to intermittent. I was looking a little bit at that. Have you heard of that? Continuous rather than just back to back stacking these?
Yeah. Thank you.
Okay.
So they're doing that a lot at children's continuous. There's really no risk. So when you think about dosing of albuterol, how much of your neb treatment do you actually think gets to that patient? So you got half in the back of the rescue with you and half in the patient, and the dog's getting the other half, right? So there's really no max dose. So I would say continuous is reasonable. I know we have guidelines for dosing here, but the joke is that you stop the albuterol when you fix them, or the heart rate gets to like 190 or something. So I think of asthma being a young person's disease. People who have significant, true emergent asthma, unfortunately, don't live a long life. So you don't see a lot of bad asthmatics later in life. If they're older and they make you uncomfortable with their wheezing, it's probably COPD. So really no risk to this. You give somebody a lot of albuterol, it will do something to an electrolyte, though. You might know what electrolyte it jacks up? Potassium, yeah. So if you got somebody that's hyperkalemic, we give a lot of albuterol. So if you have somebody that's normal K and you're giving them albuterol for hours on end, the hospital's got to check those labs so we don't get the potassium so low. But yeah, continuous is great.
And then the other thing I found, MDI with spacer can be as effective, if not more, and I think that's about the delivery, to equivalent doses of nebulized therapy for mild to moderate. And that's just the dosing is 4 to 12 puffs. And I was just thinking about that more in the situation that.
Yeah. Did anybody carry the MDI or the puffer? Or are we all doing neb treatments? Anybody carrying an MDI? Okay. Okay. Thanks. Yeah. That's when you were like in your 50s, right? Good. Sorry. Too much caffeine. Yeah. So I know that our literature now is that MDIs work better. And I think, like you said, it's probably medication delivery. We get more of that medicine to them. Because if it's a young kid, we got a mask on their face, we're puffing it in there, they have no choice but to breathe it. But again, for us, it's going to be a nebulizer, and it's going to, you give until you get better. There's really no risk to it, and half of it's going in the truck anyway. So if they need it, just keep giving it to them.
Then ipratropium also helps with bronchodilation. It works through a different mechanism, where albuterol was a beta agonist. This is going to be an anticholinergic agent. Regardless of the mechanism, the purpose is to open up the airways. So it doesn't seem like they have a ton of great research to show without a doubt that this absolutely improves, but the harm is so minimal. I would just throw it in if they were having a moderate to severe exacerbation. All the studies that they've done with ipratropium has been on initial therapy, not necessarily continuing to give it once they're admitted to the hospital. So in this setting that we're talking about is where the studies have been done. There are some smaller ones that said there were some that showed that the combo does improve pulmonary function. And then there were some smaller ones that said that there was no statistical effect on the clinical endpoints like pulmonary function, hospital stay. But those were very small studies. I think the sample size was like 67 when the one that I looked at. So the takeaway, we need larger studies and more studies. And if they have a moderate or severe exacerbation, throw it on. Try to
Yeah.
open.
Who has a dual neb? Who's using ipratropium? Anybody got dual nebs here? Because state says you can do plain albuterol or the dual neb. So nobody knows, nobody cares. Albuterol, okay, yeah, that's fine. So if you have the dual nebs, you can use those. So my therapy in the hospital is I give the dual nebs, which is the ipratropium bromide or Atrovent and albuterol, and I give 3 doses back to back. And if that works, great. If it doesn't, they get 3 more back to back. Sometimes other docs, the pharmacists, or the respiratory therapists don't like giving that much ipratropium, but there's really no risk to it. So risk to benefit, I think 3 doses, you probably kind of max out your receptors. But if I gave 6, it's not going to hurt them. So if you got a dual neb, you're not going to hurt somebody by giving them ipratropium. So yeah, either way is cool. And if they're a sick asthmatic, I'm going to give them everything, because I know if we don't break them, we have to intubate them. Their risk of dying is about 30, 40%, which is ridiculous. And it's horrible to see a young person die.
Talking about our steroids a little bit. So they reduce airway inflammation. Onset of action for these, which is why we say give these as soon as you can. The earlier, the better, to get on top of this whole process. The onset is about within 1 to 2 hours, and it peaks at 4 hours after it's been given. It's been shown to have improved symptoms and speedier recovery, decreased hospitalizations and length of stay. It's recommended for, all but the mildest cases of acute asthma exacerbation. And the way they said that, it makes me feel like just for everyone. It's recommended for everyone. So steroids are good. Like I was saying, there's no difference in the efficacy if you give it orally or if you give it IV, but we have IV, so we're going to use IV. And that was a really cool trick with the Decadron. I didn't know that. Magnesium sulfate. This is our first go-to for second-line treatment with adults. The thought behind magnesium is when you give it the 2 mgs over 20 minutes, it causes smooth muscle relaxation, opens up the airways. It has an onset of as early as 2 minutes, and it can last for an hour or 2. Some side effects to be aware of. I think it's AV nodal blockade, but it can cause some flushing, bradycardia, hypotension. Shouldn't be an issue. I've heard some people, when they did experience hypotension with it, they gave too much too fast. If that is something that you encounter, you can just give a bolus of isotonics.
Yeah, again, it goes back to your risk stratification. Is that patient sick enough to make you uncomfortable? And if they are, and they have those risk factors we talked about, MAG is reasonable for those people. So.
And then epi we touched on. So it has a dose-dependent affinity on adrenergic receptors. At low doses, it targets beta, which those are beta 2 is what's opening up our airway. And then at the higher doses, that's when it starts to act on alpha, and that's more of like our vasoconstriction and stuff that we don't need for this. But like you were saying, it can be great. It's the preferred second line in children, and for adults, everything I found is if you're worried about an anaphylactic reaction, or if they're not able to use the inhaled bronchodilators, or if they're just not responding, you can give it a go. Just be careful if they're old and have heart disease. Okay, so we've tried all of that and not getting much better. So we're going to go to CPAP now, since we've maxed out our medical management. CPAP's great. It's going to give you some positive pressure. Try to push through or push past that obstruction. Need to make sure that the patient's alert, can protect their airway. The initial settings can start at 5, titrate up to 10, and you're really just looking for work of breathing. SAT response, FiO2 start at 100, and then titrate to the SAT goals that we talked about. Things with this, or just in general with asthma and COPD exacerbations, constantly reassessing is so important. Because things can turn really quickly, so you want to make sure that whatever you're doing, you're checking back in to see how they're responding. And then obviously, if they're vomiting or severely altered, not protecting their airway. It's not going to work. BiPAP. So that's going to help reduce our work of breathing. The big takeaway with BiPAP, I'll just kind of touch briefly, but the idea is you want to set your inspiratory pressure at around 8 to 12 and your expiratory pressure lower around 4 to 5, and you want to keep the expiratory pressure low. So with these airway obstructions like asthma or COPD, you have the obstruction in your airway. To get past that obstruction, you start getting a lot of air trapping. So you want to try to prolong the expiratory phase as long as you can, meaning you don't want them just breathing really fast, short breaths. You want them to have long, deep exhalation so they can take the time to blow off all the CO2 that they need. And one of the ways to achieve this is when you're setting your BiPAP settings, increase your inspiratory pressure 2 increments every few minutes, and keep your expiratory low. So that's going to help that driving pressure to give you a longer exhalation. And then this is a nice chart that summarizes all the things we talked about. So big things we talked about, pulse ox, capnography, wheezing, but be aware of silent chest. Talked about using capnography for our shark tooth waveform, and to help see how they're responding to therapies. Keep your airway and ventilation equipment nearby. And then the differences in the second line therapy for adults versus children. And CPAP is great for these kind of things. That's all I have. I'll leave it here.
You got some questions over there, Chief?
I just sent you one.
Oh,
Talked about allergies to peanuts being associated with asthma. I'm not sure I've ever heard of that before.
yeah, I'm not sure of a correlation with that. I don't know. That's
Yeah.
for somebody that's been to med school more recent than me. I would say that peanut allergies are concerning. So those, I used to, I'm not going to say that statement. There have been times in my life that I did not respect those allergies as much as I should have. But there's some folks that have severe anaphylaxis to peanuts, and it's crazy that we see a lot more of that. The way you would manage that is like for any kind of anaphylaxis, if they have respiratory symptoms in one other organ system, you're going to treat it like anaphylaxis. So again, it goes back to knowing your epi-IM dose. That's the way you manage those folks. If they have a severe peanut allergy and they're having anaphylaxis reaction, you give them epi and they get better, but they ate a peanut butter cookie, I would bet you my $7 I got left for the month, they're going to have another anaphylaxis in the next few minutes because they digested that. It takes a while. So sometimes those guys are getting multiple IM medications for that. They probably need IV access. They need steroids. And that's somebody that you would consider, if you're giving them 3 or 4 doses of IM epi en route to the hospital, that's the one you consider calling med control and maybe starting an epi infusion. I know our protocols talk about you can use some 1 to 10,000 IV for that. I would not recommend it. I would recommend making a drip or doing 1 to 100,000, and you can even cheat and use a shock protocol for that. I would not be giving anybody 1 to 10,000 epi unless they are dead in front of you. The other thing to think about, she mentioned using epi in older folks. I kind of hinted earlier, I think when I think of respiratory distress with wheezing, this bronchial spasm. If they're younger, I'm thinking asthma. If they're older, I'm thinking COPD. So if I got a 64-year-old wheezing, short of breath, looks like dirt, I'm probably not going to hit them with IM epi. I'm going to do O2, IV access, maybe some neb treatments. And then I'm also doing what? I'm getting a 12 lead on that guy because maybe they have underlying COPD, but now their other problem is they're short of breath because they have the big one, right? So you got to look for comorbid issues for those folks, and it gets complicated. But the more of these folks you see, the more you kind of figure out how to manage them. And it's all about risk stratification and managing the things you can fix with oxygenation, support that ventilation as need be as well.
I would kind of suggest too that CPAP sooner than later.
Yeah.
Uh,
Yeah, CPAP's a great device. I think BiPAP is better, but the problem for BiPAP is agency has to have a ventilator. Those are expensive. Y'all have one down this way? I'll sell you one. I got one for sale in my trucks, $8. So that's a joke. Sorry. But yeah, ventilators are expensive. The other problem that I see with CPAP is if you get somebody that's an extremis, so they're altered, they're sweaty, they're kind of fighting you. You got to get them to work with you for CPAP, and it's tough to do that. People ask me, can we sedate these people and put them on CPAP? And I would argue, probably not. There are times in the hospital, if you watch us, we will sedate people and do BiPAP, but that gives them a rate. So we kind of remind them to breathe versus CPAP, which is just continued positive pressure ventilation, right? So for the critical care guys, using BiPAP, I think is reasonable. If I had a young asthmatic that was sweaty, altered, combative to obtunded, I'm doing my nasal cannula, my IM epi, I'm starting my neb treatments, I'm getting IV access, I'm hanging some ag. If I realize that they're not breathing well, I gotta take their airway, I'm probably gonna hit them with another dose of IM epi. And then I'm gonna use, for the critical care guys out there, I would probably use ketamine to sedate these people because it causes bronchial dilation. Or sometimes I'll put them on BiPAP and give them a little bit of ketamine to see if I can break that cycle and not intubate them. But that's somebody that it's all hands on deck. I'm working with that patient. I'm not leaving them because huge risk of that patient going into cardiac arrest. And it's tough to manage. The other advice for the critical care guys are the folks that have to intubate someone that has bad asthma. Sometimes that vent won't do you any good. So if that BiPAP wasn't working and you do take their airway, the vent's hard to manage. Sometimes it's kind of a reverse thought process. You ventilate once, you pop them off the ventilator, off the ambu bag, and you kind of move in the chest and get them to exhale. Your end tidal is going to be high. So those are just challenging patients. I can tell you those are the scariest patients as an ER physician to manage is a young asthmatic that's being tubed.
Yeah, I would add on to that a little bit. So good, very good talk, Dr. Stewart. But these patients, anyone that comes in respiratory distress used to scare the crap out of me. And now with, the advents of LMAs and adjuncts, we can ventilate and oxygenate a lot of these people. And your severe asthmatics, they still scare the crap out of me. And it's because they're having problems ventilating. And so when they get so severe to where they have the silent chest, they're becoming altered, their breathing slowing down, and you have to intubate them, that's not a good sign because they are probably going to code right in front of you as soon as you intubate them. One of the things you can do for the critical care folks to help bridge that is they're not ventilating, so they're going to be very acidotic. So you can consider giving them a couple bicarb pushes before you go to intubate. And that's just going to buy you time and hopefully bridge you to where you can intubate them, sedate them, and get them transported.
Yeah, that's true. Yeah, that's a good thought. Yeah, those are scary patients. And the COPD patients that are in extremis that you got to intubate are scary too, because now you have an older person. And if somebody has COPD to the point where they're wheezing, they're not moving good air, and you got to intubate them or bag them or do CPAP, I would argue they've been smoking more than for a couple of years, and they probably have underlying cardiac disease too. So it's just a challenging patient to manage. So, but again, these are the things you're going to see. And I would start with the kind of the building blocks, right? So recognizing that they're sick, setting them up right. And the adult COPDer is still going to be nasal cannula. She mentioned our goals of O2s. Just remember that you really can't overdose on the O2. So don't say they're 86, I want to get to 88, I'm going to give them just a little bit more. No, screw that. Give them enough oxygen to get them where you need to be. And once they get stable and start smiling and talking to you, then you titrate back down. There's a risk you take away their respiratory drive, but there's a bigger risk if you don't fix that hypoxia, they go into cardiac arrest. And you can assist ventilations if you need to, right? So airway stuff is super important. These are the people you can't just throw in the back of the rescue or your ambulance and get to the hospital quickly and think that we can fix them. You've got to start fixing them before they get to us. Otherwise, they don't get to us alive. This is where you can make a huge difference. What else you got, Chief?
Let's see here. Mike just posted.
Any questions in the
Apparently
class?
There's a correlation with peanut allergies and duoneb. There's a component in peanuts that's also an hypertropium.
Oh yeah, I'm unaware of that. I can tell you that I've never asked that question. Now, does that mean I haven't messed up? There's a good chance I've messed up a lot of things, but I'm unaware of that one. So
Yeah, I've never heard of that one either.
Yeah.
I'd say it's not true, but
yeah.
that's a new one.
Yeah, I think that, some of these folks who have anaphylaxis to anything, they have multiple allergies, so maybe something else in that medication they can do it. I've had patients tell me they're allergic to epinephrine, which doesn't make sense to me because your body makes epinephrine. It's probably a compound in the solution potentially, or maybe some dye. I don't know, but I'm not going to withhold a medication that I know is life-saving in someone like that, for the most part.
Yeah, I would offer that the biggest danger to using epinephrine in asthmatic patients is people being scared to use epinephrine in asthmatic patients.
Yeah, it's limited risk. So I want to say that that's first line at Children's. I've not worked over there in a long time, but epinephrine.
Go to the treatment steroids.
Yeah, and add in for the sick ones. Yeah. Again, it all goes back to what do you think, is this patient critical or not? So if it's the person that's calling you for shortness of breath because they were playing soccer and now they're a little wheezy and it's mid-spring, I'm probably going to do some O2, some nebs, and kind of watch them. But if it's that patient that has that history of being, admitted to ICU a couple of times, and they tell me that history, I'm going to be super aggressive to get ahead of the game, because I think the readmit rate to ICU and the intubation rate is like 50%, with the mortality we talked about is pretty high. So we see a lot of asthma that is, I won't say is not significant, but it's not life-threatening. But when you see a life-threatening asthma patient, you take care of them, it changes your whole perspective of this, because I can tell you it's about 3 patients a year in our region that has an asthmatic event and dies from that. And that's just kind of sad. And there's nothing we did or didn't do. It's just a bad disease, right? Just like diabetes and heart disease and everything else. What questions y'all have for us within reason?
Dr. Ferguson, what do you think about using the albuterol in conjunction with CPAP? I know BiPAP's better, but I don't think most of our ground crew.
Yeah, if you can rig that up, if you can make that work, yes.
I think most of the EMS CPAPs have a
Right.
place for it.
Yeah, so if you can make that work, yes, do that. That's super reasonable. And if you have a ventilator, do the BiPAP on these folks and do it early before they get an extremis, so that way you don't get to that point where you can't do it because they're confused and combative with you. Yeah. Other questions, comments, statements within reason? Nobody's making eye contact. If you ask a question, I got a challenge coin for you. Nobody's going to. Oh, there's a question. Yeah, I like this. Do I now? You can. That's usually for stridor, for upper airway obstructions, like croup or epiglottitis or somebody. I use it more for angioedema, things of that nature, cancer patients. Really is not going to help you much with wheezing. So if you had somebody that you gave 4 or 5 nebs to, they're still wheezing, they're working hard, and you have a hint that it may be beneficial, there's no risk to the medication in a young person. So probably not beneficial.
Asthma and COPD, at what point do you become concerned that you're adding to their own breath stacking?
Yeah, that's a clinical decision. Yeah, that's tough. That is tough. That's a clinical decision, right? So they need to exhale pretty good, but sometimes that CPAP helps open them up so they can kind of exhale. So it's counterintuitive. So it's gonna be a clinical decision. CPAP on, I'm watching. Are they getting better? Great, leave it on. Are they getting worse? Crap, take it off. And I hate to say it, but it's kind of, that's the way I would define it. Do you have a better medical way to define it, either one of you guys? Yeah.
Can't see the number.
Yeah, if you can't, yeah, you kind of hosed.
They'll start to develop like a silent chest. You'll see their chest get a little bigger.
Yeah.
You can always push on their chest, squeeze them, give them a big bear hug.
Yeah. Well, I want to give them a bear hug. I want to document that you hug them, but you can't push on the chest to help them ventilate. So it's a challenging thing. And again, that's what I'm saying. How many here have seen an asthmatic patient? Raise your hand. How many here have seen one that made you think they were going to die? A couple. Yeah. So they're scary to manage. Yeah. How about COPD? Who's seen a COPD patient? Yeah. Anybody here a COPD patient yourself? Raise your hand. No, me neither. Joking. Yeah. So this is a lot of things that we see. You will get complacent in managing these patients because you say, oh, I've seen Mr. Smith 12 times this year for a COPD. that 13th time may be the time they are an extremist and have a bad outcome. And you're going to feel bad about it if you don't treat them seriously every time. Same thing with your asthmatics. Be aggressive. Make sure they're not going to be that sick patient in front of you. And by sick, I mean, I define a patient as sick as when I look at him, I think to myself, holy crap, something bad could happen or you could die in the next 30, 45 minutes with me. Okay. Again, I know y'all probably heard me say it, if you watch EMS Challenge, there's limited risk to giving these people oxygen. If somebody's hypoxic and working hard, give them some O2. Okay. There's good data that O2 is bad long-term for people with underlying health problems, STEMI, strokes, things of that nature. But there's also a lot of evidence that shows in your world and my world, the ER, that hypoxia kills people. And I can prevent that, if nothing else, right? All right, any other questions or comments? I don't know what our time is. Sweet, so we're gonna do lunch here in a few minutes. If you're in the area of Chelsea, come out. We're gonna do some skills. The fire college is coming out with their equipment. We're gonna do some salad training or the vomit head mannequin, some cardiac arrest, some BLS airway stuff. We're in Troy in 2 weeks, doing the same thing down there, thanks to those guys. And then we're at the state conference in November. And then we're back in Birmingham in December. And then if you're interested, we got a couple spots open for the spring. So if you want us to come out to your area, just shoot us a text or email and we'll get you hooked up. Yes, sir.
Yeah,
Did you-
great, Dr.
Okay.
Yeah.
All right.
Thank Dr. Stuart and Dr. Kirby for great lectures. Thanks for everybody for attending. If you're watching online, there's a link to the attendance form in the Q&A section. Please fill out an attendance form, even if you don't need the CEUs. It gives us an opportunity to track who's attending and to get your feedback. If you're here in person, we'll make a QR code available for you to get that form. If none of that works for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the form. So thanks everybody for attending, and we'll see you next time.
Great. Thank you. Good job.